Welcome to tonight's webinar, The Hybrid Strength of Dual Appliances Delivers Superior Outcomes, which is presented by Dr. Francisco Eraso. Dr. Eraso practices orthodontics in the Indianapolis, Indiana area. He is dual certified as an orthodontist and oral and maxillofacial radiology. He has his master's in oral biology from the University of Louisville, a master's in oral and maxillofacial radiology from the University of North Carolina, Chapel Hill, and the orthodontic certificate from Indiana University. He is the founder and CEO of the Virtual Dental Solutions, the Agora Metaverse. He's one of the founder radiologists of Beam Readers and Diagnostic Services. He's a former adjunct associate professor at the Department of Orthodontics at IU. He's a reviewer for the American Journal of Orthodontics and Dentofacial Orthopedics, the Angle Orthodontics, and the Journal of Oral Surgery, just to name a few. Dr. Eraso's areas of interest include the community outreach, virtual and digital orthodontics, imaging and 3D reconstruction, teleradiology, and advanced imaging for orthodontics, TMJ, and airways. This webinar, you will gain insights into smart case management strategies and learn how to integrate cutting-edge orthodontic solutions to maximize case acceptance. It is my pleasure to introduce Dr. Eraso.
We are going to talk about using technology to maximize case acceptance. My name is Francisco Eraso. I'm an orthodontist and an oral and maxillofacial radiologist living in Indianapolis, Indiana for almost 20 years. I went to school, dental school in Colombia in 1992, and I did my 2 or 3 residency programs in the University of Louisville for oral biology. I did my master's and my certificate program in the oral and maxillofacial radiology at the University of North Carolina. I'm an orthodontist from Indiana University, practiced in Indianapolis, like I mentioned to you before. I'm one of the founder radiologists for Beam Readers, which is a diagnostic service company that read X-rays, mostly CBCTs. And the founder and the CEO of Agora Metaverse, which is a virtual dental solution for education that we are preparing for a lot of people these days. So my presentation usually tells everybody part of my story, how I practice orthodontics these days. So the best results start with an adequate and complete diagnosis. Nothing is more important than diagnosis. So if we are going to talk about hybrid cases, the most important part is diagnosis, because from the diagnosis and treatment plan, we can move to different directions. Aligner, braces, hybrid treatment, good results, excellent and compliant patients, and short periods of time in your treatment. The way that I practice in my office is the patient will start at the beginning with a clinical exam, which nothing replaces the clinical exam. I connect with the patient at clinical examination, and of course, I order a set of records. The set of records is something that everybody does, photography. In my case, I use CBCT in all of our patients, and of course, we do the intraoral scans using the different scans that we have in our practice. Once I have that information, I realize something that I call a treatment conference, where I review with the patient, if the patient comes back for this conference, review the radiology report. I discuss the renderings that I do, if I do three-dimensional renderings, and then I propose a treatment. Before I concentrate only in braces or aligners, today in my practice, I'm suggesting a lot of hybrid treatments. But in the diagnosis and the treatment plan session, I visualize the end before we start. With the digital imaging, especially now with the digital treatment plans, we can visualize the end before we start. So we can visualize how the teeth are going to be aligned if those movements are possible. We can visualize how we are moving teeth with aligners or braces. However, what is more important in your diagnosis and treatment plan is the visualization of structures of importance for moving teeth, which are the roots and the bone. That is why I use three-dimensional imaging for all of my cases, so I can really visualize the end before we start. So once I take my records, I segment all of the anatomy and all of the pictures in something that I call imaging portfolio. In the imaging portfolio, the first page, like I always mention in my lectures, is a summary of all of the findings, photographic pictures, images of the airway spaces or renderings, and I also quantify the airways because we are not straightened teeth only. We are also affect different structures with our treatment results. Of course, we do a panoramic X-ray, but the panoramic that I produce doesn't have any distortion, but that will allow me to really see the surrounding bone, rule out pathology, rule out impactions, and the root parallelism, how I need to position those roots in the dental arch. Of course, the lateral cells and the PAs, and the other structure that I'm very, very careful to evaluate is the temporomandibular joint. Once I have that, then I review one by one the photographic pictures. This is my son, the oldest. Then you have the panoramic X-ray, beautiful panoramic. Then I look at the airway spaces. Then I quantify the changes. I quantify the spaces and the airways. This is not a lecture for radiology, but it's important that you are not concentrated only in aligning teeth. You are going to impact the maxillofacial complex structures. So airways are extremely important because we need to quantify it if we expand or if we move the jaw in the AP direction, what is the effect on the airway spaces. So we have to quantify the initial findings. Then I look at the TMJs, the position and relationship of the TMJ or the condyles in the glenoid fossa, and also if there's any changes, the generation, changes in the vertical dimension, changes in the AP, and I'm going to know that. Those findings are going to guide me and provide me a green light for treatment. Once I have that, now we can talk about the hybrid treatments, how they strengthen dual appliances delivering superior outcomes. Remember, the most important part of the treatment is the diagnosis and treatment plan. Then we can talk about hybrid treatments. And the topic for today is the hybrid strengths of dual appliances, aligners, or braces to deliver superior outcomes. For that, I'm going to show you some examples, and I'm going to tell you how I practice in my office. So this case, Amy is a mixed dentition, early mixed dentition patient, doesn't have any space for the maxillary canines, has a little bit of space for the premolars, doesn't have too much transverse dimension, doesn't have that much crowding, but doesn't have that much space for everything. So the first part of the treatment, which actually was a long time ago, and I never thought about doing something that I call hybrid treatment in this case, because this case was the typical phase one, phase two treatment. In phase one, we start in the mixed dentition. I do expansion, 2x4, create the space for the proper eruption of the permanent teeth, avoiding extraction of permanent teeth, like bicuspids, and then we can do phase two. When the patient came back, we have a space for the canines, we have a space for the premolars, and we try to finish everything in the second phase. Great treatment. We have maybe a year in the phase one, we have 12 to 14 months in phase two, and we finish the treatment. The problem is when the patient is so happy in this situation, we use her, the happiness of her treatment we use in our social media pages, and then the patient come back and we have this situation. The patient open bite, posterior one, mildly posterior and anterior, but the reason of that posterior and anterior open bite is because of the supra eruption of the second molars. My mistake. I like to talk about my mistakes, because I'm not perfect. I look perfect, but I'm not perfect. And so the problem that I have in this case is supra eruption of the second molars because my retention was not designed properly. So I put an S6 retainer with the fixed retainers, but the second molars over erupt, opening the patient's bite. The patient came back to the office and everything looks straight, but with the open bite. So we are not going to offer braces. The solution that I offer is a hybrid kind of approach. We start with braces, we're going to finish with aligners. So I propose some aligners. And this is the treatment that we have with our MOV Aligners. So as you can see, there is no problems in the alignment, is no problems in the transverse dimension, there's no problems in the upper or lower arch. The problem is the supra-eruption of the second molars, which brings anterior open bite. Now that we are going to do a treatment, we are going to improve because of that relapse of the facial midline. We are going to do some interproximal reduction in the lower incisors in the first stage. We're going to design some attachments, and we are going to intrude the upper teeth, and we are going to settle the occlusion in a better place. So this is the treatment, 10 aligners, and we are proposing this to the parents and of course to the patient. The patient is in agreement with the compromise of wearing of the compliance. So we propose the treatment and we bring the patient 5 weeks later. In this case, we are wearing the aligners with the 1 week protocol, and look at the changes that we have only in 5 weeks using aligners. Compliant patient, good hygiene, no problems in the alignment. Now we are settling the occlusion into a better occlusion. We are correcting the midline. We're in half part of the treatment, and we have incredible results. So the diagnosis for this patient was good in the early stages because we create a space in the transverse dimension. We finished the case. I made a mistake in the retention, but I make a good diagnosis because with the open bites, I have to rule out some things. For example, when you have open bite patients, the first thing that you have to do is the TMJ to rule out degeneration, because the degeneration, when there are changes in the condylar vertical dimension, the patient opens their bite. And so this case, we rule that out. And now is a dental treatment, intrusion of the posterior teeth in the maxilla, settling the occlusion, and we are detailing, correcting better the sagittal dimension or direction in the right side. Here in the left is okay. And of course, we're improving the midline. Good results so far. Now let me show you something, another case. The hybrid approach that I have in this case was not by design. Is because the inefficiency of my mechanics and inefficiency of the brackets that I choose. So the patient doesn't have that much of a crowding. It has a lower incisor. It was missed a lower incisor, and you have a huge diastema. At one point, she has some periodontal problem, and we are going to solve that, closing those spaces by placing the brackets in the right place. Okay, so I say, okay, we're going to design the treatment. With this case, we went with aesthetic brackets because the patient wants something more aesthetic. I decided to go with the Life Force gray system, and we position the brackets in the right place. Arch wire sequence. We change the brackets every 8 to 12 weeks. For the first session, we arrive into a more kind of like a round or more like a steel wire, and we finish the case. So we are correcting the bite, we are closing the spaces, and we are finishing the case really good. The treatment was designed in my mind for 12 to 14 months. After 2 years, I was still here. Okay, great alignment, but I couldn't close these spaces. Even though I have the space, I have the overjet, I couldn't close those spaces. And it was making me crazy. Okay, closing this space with conventional brackets or with metallic brackets or the self-ligating brackets that I use is a very simple task. Closing these spaces with, in this case, for this patient, with the ceramic brackets, with all of the friction and all of the mechanics that I was using, nothing fancy, sliding mechanics, didn't work. So I have to give the patient a solution that is going to not increase the time, not increase also the money that she will pay for the finishing of the treatment. So I decided to go with the MOV Aligners. We took some records, we proposed some treatment, we did some attachments, and in 10 aligners, we are proposing closing the spaces for the most simple way. Aligners are a good system to do that. So we are closing the teeth, or the spaces, I'm sorry, very simply in the upper and the lower arch, especially in the lower arch. There is no problems as far as bone support. Remember, I took a CVCT to make sure we have enough bone support in the lower incisors, because sometimes what is happening is you are closing the space or trying to close the spaces and you don't have bone. So literally cannot move roots through the air. So now we are moving the teeth into the bone. We're closing the spaces with 10 aligners. I think we want to do this treatment that way. In 10 weeks, we have beautiful smile line. We have closing of the spaces in the upper arch, really a small space in the lower arch. But remember, because of the extraction of the lower incisor, the patient has an increase in overjet. The patient is extremely happy. Of course, we want to close this space in the lower arch, but I want to take the opportunity, like all of our orthodontists, to improve the overjet and improve the anterior overjet. And I did a refinement, and we're in the process of do that. So we did some uh, interproximal reduction, and we are finishing the case the most simple way, which is a nice refinement with little aligners for this case. So in summary, I started cases with the perception of putting the brackets in the right place, using a sequential arch wire that I always use. I decide to go with aesthetic brackets and using life force. My mechanics in my hands for this case didn't allow me to close the spaces properly and on time. So the second stage for this space was to offer something that I feel comfortable, which is aligners. The MOV Aligners are giving me excellent results for these simple and complicated cases, but for these simple cases, the other beautiful thing about the MOV Aligners is you can take the impressions with intraoral scanner with the brackets on. So we can make a design and we can make decisions without taking the brackets off, without making commitments before taking the braces off. And we are proposing to the patient. The patient is very happy with the time. I'm very confident with the treatment plan that we designed, and we are doing a good job in this case. Then we have David. David is also a case that we finish, and we start the case with a very simple diagnosis. You know, the patient wants aesthetic brackets, so we decided to go with the Life Force again. At that time, I was really excited with the digital technology, and I think Life Force still present a good solution for a lot of people. However, in my hands for these two cases, for this one and for the previous one, I couldn't finish the case properly for many reasons. One of the reasons that occur with the clear brackets, they are very fragile, they are very brittle, so they break a lot. Fortunately, you can replace those brackets very easily by ordering new ones, but that means you have to reposition the patient or kind of rebond the brackets again, and kind of that delay the treatment. In addition to that, a very simple treatment is a molar and canine class 1 in the right and in the left side, arch discrepancy or crowding in the upper, mild in the upper, more severe or moderate in the lower arch, mostly in the anteriors. So I'm going to correct that, but by using the right sequence of arch wires. In my opinion, if I redo this case again, I will use self-ligating brackets, and we can use the experience brackets, for example, the brackets that I used since my graduation in 2005 in IU. And we can use self-ligating brackets and finish this case really fast, okay? But the patient want a more aesthetic solution, I want to try the digital solution that LifeForce offered me. And of course, I started the case. The case was going really well. Okay. This is the treatment plan for the case. Nothing fancy, huh? Engaging the wires in the brackets, arch wire sequential arch wire changes, and we are finishing the case really good. At that time, we didn't have the ability to bond the second molars. Of course, we bond the second molars manually, but we couldn't do it digitally. So that is an addition that I have for this case. But that was not the problem. The problem was that while the results look very promising, what happened after a period of time, almost like a year and a half, close to 20 months, the space is open. Okay, so when the space is open, there's two ways, the two things that happen when you increase the arch dimension and maybe you do a little flaring. Sometimes the space is open. And these spaces right here and right here were extremely difficult to close. Maybe I'm not the best orthodontist in the world, and I'm not claiming that, but it was extremely difficult to close those spaces. Many reasons. The patient broke a lot of brackets for sure, friction, and the inefficiency of me with my mechanics to trying to close those spaces. Nothing fancy, power chain. I use ligature tires. I use every trick that I knew, and I couldn't close that space. I closed it, but I closed it, and every time relapsed. So the patient was really frustrated. And at one point, I told the patient, you know something? Let's go ahead and take those braces off, and let's finish with aligners. Let me use something that is called a hybrid approach, finishing and detailing with aligners. The beauty of finishing and detailing with MOV Aligners is that I can take the impressions like that. Okay, so use my intraoral scanner. I use, in this case, the iTero scanner, and they digitally remove the brackets in the computer, and we do the treatment plan. The treatment plan with the MOV Aligners was 10 aligners again. The attachments, this was one of the first cases that I did with MOV Aligners. The attachments were a little excessive as far as the size, but they were very efficient. So treatment plan start with the first aligner. Oops, sorry. That's how we start. Start with the first aligner. We did a little bit interproximal reduction. I was reluctant to do interproximal reduction with the brackets because I couldn't close the spaces. So the patient was a little kind of like okay, well, why we're increasing the space? Because we want to fit everything and detail. It's not just to close the spaces. We're using the aligners to finishing and detail and make the case perfect. So the hybrid approach is using the advantages of the systems to make the case perfect at the end. So, of course, we didn't do anything in the posterior segment. We just closed all of the spaces in the anterior. We're using some elastics to make sure the case in the canine settles okay. And this is how we finish. 10 weeks. 10 weeks means we use, with the MOV Aligners, in some of the cases that are very simple like this one, we use 1 week change aligners of 7 days. And in 10 weeks, the patient has finally those spaces closed. The patient feel the liberty to have good hygiene. The patient feel like the results were like I presented with the LifeForce before, and very comfortable with the results. So in summary, the two cases that I have, the hybrid approach works this way. When you feel uncomfortable in your cases, you almost close, and you don't want to go in and out, and having the patient frustration, you are frustrated, everybody's frustrated with the case, you need to stop and rethink. In the school, I remember, with Dr. Eugene Roberts, one of the best mentors that I have. I have many mentors in my life. Dr. Donald Tyndall in the University of North Carolina, Alan Farman, the University of Louisville, two great radiologists. But my mentor in orthodontics is Eugene Roberts. And Eugene was very complicated in his mechanics, but he said you have to finish the case perfect. And I remember we went over the ABO standards, and we qualified every case, qualified every grade. I'm sorry, every case, and we have to finish the case perfect. And he graded us every single case. So we try to finish every case as perfect as we can. So when we are close to the end, I remember in the school, we took some impressions with the brackets on, and we analyzed the case, because sometimes we are looking at the case in so many ways and we are not seeing the complete details and the full scope of the problem, if it's any problem. So it is extremely important that you stop, you take an impression. The beauty of the MOV Aligners is you can take impressions with the braces on, and you analyze and you make sure that what they propose and where you are correcting and propose makes sense, present it to the patient. And when you present a patient a treatment that is only 10 aligners and you're finishing everything that you promised that you're going to do in the past, and you finish it only in 10 aligners or 10 weeks, I think the patient is going to say, okay, how much is it? In these cases, I did extremely good discounts because it was part of my problem, my mistake. But in some of the cases, what I'm doing is I am level on a line, and then maybe I finish the cases with aligners. So let me show you my approach. With GC8, with GCA, I'm sorry, GC America, we have is characterized by something that we call gray chemistry. In the gray chemistry is not only the chemical products, is the people, how we change people's lives with good products. So GCA has materials, brackets, now aligners, and it has good people behind the product. So GCA for me is the champion in my practice, and I use it since finishing orthodontic school. And my best friend, one of my best friend is Mike Knudson. Mike Knudson is the rep from GC for years. He used to work for different companies, but now, and I'm following him. I'm following him wherever he goes, and he arrived to GC America, and they in GC, when GAC closed the company, they inherit the experience brackets. Remember, they were called innovation brackets. So the reason why I went with GC America is because of the experience brackets or the innovation brackets. The wires are perfect because of the ability to have um, uh, biothermic wires. And so I use those aligners. Perfect wires are going to reduce treatment time. And now we're going to talk about bracket placement using digital technology. Then they brought the MOV Aligners. So great products are going to apply to great people, the people in my patients, the people that support GC. I know a lot of people in the company because I have a personal relationship with them, because they became my friends too. So great people, great products will produce great chemistry for our patients and for everything that you want to do in your practice. So I strongly recommend this is a platform for them, but I'm extremely happy, and the great chemistry is what GCA is. GCA allow me to create something that I call the hybrid protocol. The hybrid protocol is a protocol that a lot of people know, but this is the hybrid protocol that I use, okay? I do the initial records. Remember, in the initial records, I take photos, CBCT, extremely important, and you are going to see why. CBCT and the intraoral scan. I do my treatment plan with the IDB or the indirect bonding system, with GC system or DIPS. I use experience self-ligating brackets 022, and of course I using the beauty of the wires that they have. Then when I have the GC or DIPS AI indirect bonding setups, I do the initial bonding, I do the initial arc arch delivery, and I have sequential arch wire changes. So I usually use 014 or 018, depends on how much carotid you have. I leave the wires for approximately 10 to 12 weeks every appointment. So in a year, I most likely have 5 appointments. Then I go into a square wire, the 2020 bioactive, and I finish my case with a 1925. This sequence usually is done in 6 to 8 months. Okay. And the reason why I'm confident of that as sequence is because I'm not trying to finish the case. Okay. When I use digital technology and I press the brackets in the right place, I'm going to have consistent level and align and a really good detail. Okay, detail as far as root placement. Okay, the reason why I'm confident that I'm placing the roots where it is because I use CVCT technology. I render in the roots, I make sure that I see the bone, and now I have a really, really good bracket placement. So if for any reason I have to do a sagittal correction, I do the sagittal correction first. Personally, I use a different system, but GC has also a sagittal correction system that you can use. Then when I finish that, I do an intraoral scan with braces on for MOV Aligners. The reason why I don't do aligners first or I don't do aligners all the way is because I'm going to really lift the heavy weight first. I remember Luis Carrier will show me that. Do the heavy lifting first and then you finish the case. The heavy lifting is to really, really correct and do the root position with braces and then finishing and detailing the cases with move aligners. A lot of people are going to say, yes, but you're spending a lot of money. Not necessarily. If you use the DIPS or the GC system for indirect bonding, use the right edgeware sequence, which is 3 wires or maybe 4 wires, and then you do move aligners, the case for sure, I'm going to tell you, is going to be less than $1,000. A lot of people are paying almost 2,000, 2,400 for just Invisalign with the poor possibility that they are not seeing the roots. Not because they don't want it, it's because they don't use CVCT technology. So now you have, in addition to have a weak system to start with, now you don't have the roots in the treatment planning, and you're going to have a lot of refinements. Every appointment counts in the treatment uh, plan and the treatment length, okay? Every appointment counts and every refinement counts. Invisalign or any aligner company can give you so many refinements, but you don't want a refinement. You want to finish the case in the first set of aligners. So of course I use aligners. Now that I did the heavy lifting first, I use in 10, maximum 20 aligners, total treatment time, 12 months. Now, the beauty is now when I achieve these results, I need to have retention. We do the final records. The retention or the final retainer are included with the move aligners, and the additional retainers are very economic. And now that you have a digital record, you can order it from the system. So a very cool hybrid protocol using experience brackets, using move lines, of course, all of the wires that we have from them. Now, remember, talk about great chemistry and great products. GC also has good system or good composites for the attachments. Okay, good systems for hygiene and good systems for wires. So the hybrid protocol is everything in one. Okay, so the hybrid protocol will allow me to finish the case, reducing the amount of money that I spend and optimizing the results. So from the initial records to the final records. So the T1 to T4, my goal is to finish the case in 12 to 14 months. Really using CVCT technology, using a good diagnosis, using aligners as well. A lot of people are like, okay, I'm spending a lot of money here. So if I'm charging $7,000 for a treatment, I better at least spend $1,000 doing things right. So that is my approach. That is my hybrid protocol. And let me show you a case. We have maybe like 5 more minutes. And my first case, that I'm going to show you, or this case that I'm going to show you as far as the hybrid approach, which I don't think we have more time, start with a mixed dentition. Okay, early mixed dentition, class 2 relationship, unerupted incisors, unerupted lower incisors. So the only teeth that were erupted were the molars, which were in class 2. When I did the combing, I found that the patient has discrepancy in the transverse dimension, and in addition, you have problem in the airways, adenoids and tonsil hypertrophy. Wow. Okay. Then you have here the reduction of the airway spaces. You have tonsillar hypertrophy. Adenoids were okay. The airway spaces, the dimension of the airway spaces was reduced. So the goal of the phase 1 in this case was creating a space for all of the teeth to erupt. The last thing that I want in Nico, this is a patient that is one of my patients, is to extract teeth for the teeth to come and fit in the arch. So I'm going to do as much expansion as I can. I'm going to maximize the airway space dimensions by, of course, referring this space to an ENT for tonsil adenoidectomies, adenoidectomies and tonsillectomies. And now you are going to see the results. Look at how beautiful the airway spaces are after the tonsillectomies. Superimposition before and after. Look at the tonsils, look at the adenoids before, and look at after. Great. So that is why three-dimensional imaging are really, really good for that. In addition to this, I'm playing my role of a radiologist now. And in addition to this, I use a tool called Anatomash. And the Anatomash rendering all of the roots at that time. This was before COVID, okay, this case. But I have the ability to render all of the roots. And I was thinking at that time, it would be so cool to use this tool for indirect bonding. So I was having that in mind. However, this was more like a treatment planning sessions, dreaming about how I'm going to create the space, how I'm going to bring everything into the arch. That is called digital treatment planning. So we create some expansion. We rendering all of the baby teeth. We rendering all of the maxillary permanent teeth. We're going to extract some baby teeth, okay, because actually the central incisors and the laterals were not erupted. So the one thing that I want is to allow these central incisors to come in by extracting the lateral baby or primary teeth. Then with the expansion, we are going to create that space. Then unfortunately, I have to extract the baby canines. So we have a space for the laterals. Then I create some mechanics with expansion to create a space for the bicuspid. When the bicuspid is in, I create some space for the canines. So expansion. Once I create expansion, I create a space for all of the teeth. And then I have the two centrals in. When I have those two centrals in, you see that the laterals didn't have any space. So of course I extract the canines, and I told you the sequence. Extraction of the canines, the laterals are in. Now we are going to eventually at one point extract the first molars, create a space between the laterals and bicuspid when the bicuspids are in. Once the bicuspid is in, the canine kind of unlocked and will come down easily. Of course, it's not going to happen in 1 year, 1 month, but they will come. Okay. Nico was a very cute patient when we started phase 1, and Nico came back for phase 2. The beauty that I did in phase 1 was allowing everything to come in. Okay. And if you remember in this picture, okay, one thing that I didn't see in the phase 1 was supernumerary teeth. Okay, as you can see in the mandible, I can count the third molars, second molars, first molars, bicuspid, canine, the incisors, and I don't see anything here. Okay, so he came for phase 2, came to my office. Actually, he lives in Florida. He wants his uncle to do treatment. So I said, come on, I will pay for the ticket for the records. And he came. Great expansion. You see the dimension, transverse dimension of the arch is good. He settled into nice class 1. So the treatment was going to be very simple aligner treatment because he was living away, easy for treatment. So I took the records and suddenly I saw 3 supernumerary teeth. I don't know how that happened, okay? But this is, of course, family member. And you have 3 impacted teeth. Towards the lingual, we did some records. We sent it to an oral surgeon in Miami. You have the first supernumerary tooth, the second, and the third. I never saw that happen, and of course, it happened in a family member. And of course, we have to do the extraction of that. Now that I see the roots, I don't want to mess around with the roots. So I want to see the roots when I do the treatment plan. I want to put the patient in brackets, and I want to do the first stage with brackets and finish the case with the hybrid approach that I mentioned to you, which is doing the aligners and finish the case. I use for this case the DIPS AI, which allow me to place the brackets in the right place, create a rendering how the teeth are going to look after the treatment, nice correction and arch shape in the upper and in the lower, correction of the malcrotum. And then the way that I review treatment is first I review and make sure that the position of the brackets are correct. Once I have that, once I have everything according in the position that I want, then I put the roots. Because I took a CVCT, I can render the roots. Now I make sure that the position and the parallelism of those roots, like they taught us in dental school and in the orthodontic program. Once I have this case done, in 6 months, remember, we start with a simple 014, 018, 2020, and maybe still in 6 to 8 months, I finish the phase 1 of the treatment, and then I take the scanner with the braces on and finish the case with aligners. So what I'm going to do when I finish the first session, I'm going to move into MOV Aligners and finish the records. I'm going to finish the case for sure by the end of the year because I just started the case, but I want to show you my hybrid protocol. The hybrid protocol, the introduction of the CVCT is extremely important because the MOV Aligners still don't have the CVCT. We put the power of the CVCT into the DIPS AI system, and we are going to use the right brackets. Then the first section, the first and the second section are going to be extremely powerful. The MOV Aligners are going to be the final touch, and the final records and the retention are going to be done by the MOV Aligners and having a good case in less than a year. So these are the cases that I'm starting with the MOV Aligners. So I am ready for the hybrid revolution. Are you? So the hybrid revolution, let me tell you, you can start with aligners, finish with braces, but the most important thing is, please use the roots when you do treatment plan for your orthodontic patients, because we are moving roots through the bone. The powerful brackets, any brackets I use, but I use the experienced self-ligating brackets. If I use a power set of brackets, position in the right place, seeing the roots, and then finishing the cases with the aligners are going to be extremely powerful. So now I'm 40 minutes in the lecture, and I'm going to thank you, all of you, for still being here. This is my information, my Instagram, my homepage, and of course my email if you want to send me an email or send me some questions. For sure, I'm going to listen to some questions and take some of the questions that you have. And I thank you for all of your attention, and I'll see you at the AO in Philadelphia.